Okay, welcome back. Apparently everyone can hear my voice, so that's always a positive thing. Welcome to today's webinar on laser therapy for sciatica. My name is Dr. David Kanashko. I'm a chiropractor. I'm also trained in traditional Chinese medicine and acupuncture. I work in the clinic here in Toronto. We have a very large outpatient laser therapy clinic. I'm also involved with obviously education and research and training for photobiomodulation, which is the actual scientific or research term, but most people, most clinicians refer to it as laser therapy or low-level laser therapy or cold laser therapy or something along that lines. So before we get started with today's webinar, I want to thank you all for joining me. I appreciate you taking time out of your day to do that. I typically broadcast 2 to 3 webinars a month, typically for healthcare professionals. However, anyone can listen in. And I also do a separate webinar stream for our home devices, our personal systems, more geared towards the general public as opposed to clinicians. And again, clinicians are welcome to listen to those webinars as well. My background, I mentioned I'm a chiropractor. Also a molecular biologist back in the day, which got me interested in the mechanisms of how photobiomodulation works. The goal of today's webinar is to understand a little bit about sciatica, which is a kind of a loose term thrown out there that patients will hear about or think they have. But of course, we as clinicians know that sciatica is more of a symptom and not necessarily a specific diagnosis. So we need to understand what causes sciatic pain or sciatica-like pain, so we can target it appropriately with laser therapy. I'm going to go over basically some of the anatomy and epidemiology and so forth, a bit of the research involved with laser therapy, the ways of approaching pain and healing with laser therapy for patients with sciatica. We'll have times for Q&A at the very end as well. Hope everyone is healthy and staying safe. All right, well, let's get started. By the way, you can type in any questions along the way. I will have time for questions at the very end, so just type them in as we're going along. I also record all these webinars, and once we edit them, we send out a link. Excuse me, I will cough from time to time only because it's dry in here, not because I'm symptomatic. We record the webinars, and you will be sent out a link to watch it again. So we do that, but you have to register in order to take advantage of that. Otherwise, they are put on our support page on our website, and of course, that's for BioFlex users only. All right, let's see if I can get this to work. There we go. So I mentioned we'll go over a bit about the anatomy, the definition of sciatica, talk a bit about the etiology and epidemiology, a bit of the research associated with laser therapy and sciatica. I'm going to talk specifically about how you would use our devices and laser therapy in general to treat this type of condition. I will present a case study just to give an idea how we think a little bit outside the box when we're treating these patients, just so you understand about how to customize the protocols if need be. And then we'll have time, again, I mentioned, for Q&A. So again, I'm not going to spend a lot of time on the anatomy. Everyone's aware of the sciatic nerve originating from spinal nerves in the upper lumbar spine all the way into the sacral nerves, forming the lumbosacral plexus, which then forms the largest nerve in the human body, the sciatic nerve, which has a circuitous path. Of course, we know that it can, in proximity to the piriformis, that may be an issue as well, traveling down the back of the leg and supplying the lower extremity. Piriformis muscle, obviously, it's one as a chiropractor, massage therapist, or manual therapist, we oftentimes will treat. It can cause sciatica-like pain. I'll talk a bit about that a little bit later. But of course, we need to know the relation of the piriformis to the sciatic nerve as well. Intervertebral disc, which is pretty much one of the most common causes of sciatica. The anatomy, of course, it's a fibrocartilaginous joint. It takes up about 1/4 of the length of the entire spinal column. That's why we shrink as we age, because the actual integrity and the thickness of the disc will reduce as we age as well. And of course, it allows for compressive, tensile, and rotational motion. Not very much, but when you add them all up, of course, it's substantial. And it's the largest avascular structure in the human body. So in other words, it doesn't have direct blood supply, makes it very challenging to heal, especially heal quickly. It consists of an annulus fibrosus, an outer portion, which has lamellae of collagen. They're arranged at different degrees, orientation obliquely, and it has contiguous layers, giving it great tensile strength. The center of the disc is the nucleus pulposus. It's a gelatinous, fairly high water content structure. Basically, it resists axial forces to help reduce compression of our nerves in our spine. Blood supply, as I mentioned earlier, there's no actually specific vascular blood supply of the disc. It receives it through diffusion through the vertebral body end plates. There are a network of blood vessels centrally in the end plate of the vertebrae, and allows these nutrients to diffuse directly into the nucleus pulposus and annulus fibrosus. So again, one needs to understand that if you have an injured disc, it ain't healing very quickly. Sciatica itself refers to pain and or paresthesia. So those are the symptoms, which is through the distribution of the sciatic nerve and or the associated lumbosacral nerve roots. The pain itself of sciatica typically radiates along the course of the sciatic nerve and typically down into the buttocks, back of the posterior aspect of the leg itself, and almost always below the knee. So that's one of the things that we need to understand. Is it true sciatica or is it pseudo sciatica? Sciatica is specific to the pain that is direct result of the sciatic nerve or sciatic nerve root pathology. So that's what we're talking about when we talk about sciatica. Any condition that can structurally impact or compress a sciatic nerve can lead to sciatica-like symptoms. However, the most common cause of sciatica is usually a disc bulge or herniation in the lumbosacral region. So there's different stages to disc herniations. Oftentimes you'll see degeneration in the disc. It can be through an actual event like heavy lifting, but oftentimes it's due to degeneration and weakening of the annulus fibrosus, causing a prolapse of the nucleus pulposus. And if severe enough, it can start to extrude through the entire layers of the annulus fibrosus and then sequestrate all the way out into the canal. Not very much fun if you have that. In the elderly population, stenosis, spinal stenosis can also cause sciatica-like pain. This is a really common condition. You'll see it a lot in clinical practice in folks that are usually a little bit up there in age, and usually in their 60s, 70s, 80s and beyond. And it's a really debilitating issue. Really affects the patient's ability to walk and ambulate. Then they get weak, and it's just not a good thing. Another cause for sciatica can be spondylolisthesis, which is basically movement of one vertebral body on the other in relation to each other. And this misalignment, you might say, or shifting can actually stress and put pressure and or inflammation and irritation on the nerve roots leading to the sciatic nerve. Another one that you'll come across, and sometimes it doesn't seem like that it's happening, like, as far as, well, this is causing sciatica, but it actually can be due to spasm of muscles, usually in the deep erectors of the lumbosacral region, pelvic region, and this spasm of muscle can actually irritate and compress or put pressure on the nerve roots or the plexus of the nerves leading to the sciatic nerve. So it can actually cause sciatic symptoms. This is usually the quickest kind of sciatica to resolve because you can get the muscle spasm reduced fairly quickly if you know what you're doing, and this will really help the sciatica-like symptoms. Of course, there's other more ominous conditions that can cause sciatica, everything from malignancy and epidural hematoma. I don't know if you guys were watching the news of late, and they talked about this woman who had a epidural needle lodged in her spine, like, I don't know, 10 or 15 years later. And they couldn't figure out, because it was so old, they couldn't actually figure out what doctor was involved with or surgeon was involved with this malpractice. So now she has a needle stuck in her spine, scar tissue, and they can't remove it because it's too dangerous. So yeah, so I don't know if she has sciatica-like symptoms, but she wasn't too happy anyhow to hear about that. Epidural abscesses can cause sciatica mass. Anything that causes a mass-like effect, compression can cause sciatica symptoms. So these, of course, mostly are contraindicated to be treating with laser therapy. It's also important to understand that sciatica essentially results from an inflammatory condition, and at least the irritation of the sciatic nerve. Unfortunately, low-level laser therapy really allows, through its mechanism of action, to decrease inflammation. So it's very helpful in treating sciatica. Of course, you can also get direct compression of the nerve roots and the nerves as well. And this direct compression, if severe enough, can actually cause things like motor dysfunction, so weakening of their muscles, eventually atrophy if long-term, reduced deep tendon reflexes. That's the scenario where you're looking at a much longer recovery and sometimes requires surgery. You have to be really aware of what's going on. So make sure you do proper neurological testing if patients are presenting with sciatica. So sciatica itself has some unique epidemiological characteristics that doesn't seem to be male or female dominated. The peak incidence seems to occur in the 4th decade of life. It seems to have a lifetime incidence of anywhere from 10 to 40%, so it's a really common condition. It rarely occurs before 20 unless, of course, someone blows out a disc or something of that nature. And there may be a genetic predisposition to it as well, too. It could be how the bones are shaped. It could be other aspects of genetics for leading to sciatica. Also, certain types of physical activity can increase the incidence as well, especially if you haven't had any prior symptoms. Occupational predisposition, that makes sense. A lot of vibration through truck driving, machine operation, specific jobs where workers are physically using their back in awkward positions, especially lifting, bending, and twisting, leads to earlier degenerative changes or tearing, micro tearing of the annulus fibrosus. Okay, piriformis syndrome, I throw this in because it's oftentimes misdiagnosed or unrecognized. It's funny, that quote is from a medical journal. I think chiropractors and anyone, physios and the like, we all are very familiar with piriformis syndrome, so it's really on our differential diagnosis list. So we don't usually miss it too often. But the issue here is that the piriformis is very close to sciatic nerve. So if the piriformis is spasmed or inflamed or injured or what have you, it can actually irritate the very adjacent sciatic nerve. It's usually due to overuse injuries that can cause this inflammation, and it mimics sciatica. So what you tend to see is you have patients that these symptoms will be brought on if you put direct pressure over the piriformis muscle. It increases symptom-wise if they're walking up inclines or stairs. And you'll see a decreased range of motion of the hip joint because, of course, the piriformis attaches to the femur and affects movement of the hip joint. A bit of research with respect to sciatica. I'm going to focus more on the research around how it can help with pain and to some degree, obviously, healing as well. This particular paper looked at trying to induce analgesia on nerves. And specifically what they've determined is that if you have a very high irradiance or fluence, which is milliwatts per centimeter squared, if it's higher than 270, 300 milliwatts, and this is at the site of the inflammation or the inflamed nerve, you can actually, and fairly quickly, block pain transmission. Again, you have to know what you're doing in order to do this with laser therapy. So you can do a combination therapy if you wish, and that combination therapy would be firstly, initially with a very, very high irradiance and fluence to reduce pain fairly quickly. But you, of course, want to use much lower irradiance and fluence energy rates in order to help with inflammation and help with the healing. So more of a long-term type of prolonged pain relief. We tend to recommend the second option, but I get it. Sometimes people just want out of pain and now, in which case you would just be increasing your dosaging. I'll talk about that shortly. So laser light, specifically, you can induce analgesia if you're using a laser. If the irradiance has to be pretty high. I mentioned 300 milliwatts or even higher. And what this does is it exerts an inhibitory effect on pain fibers specifically. It slows the conduction velocity, reduces amplitude of the AP or action potentials, and suppresses neurogenic inflammation. Roberta Chow, I don't have the reference here, sorry, I completely gapped on putting it in, but Roberta Chow is a medical doctor and also a PhD out of Australia, and does tons of great research on pain, especially neck pain, and has looked at the mechanisms of how laser therapy can reduce pain. She did some great research and she found that it blocks the anterograde transport of mitochondria, so ATP-rich mitochondria in the dorsal root ganglion and down the nerves. And I'll talk about that very shortly. So getting back to our equipment, we have two types of laser probes, an LDI 200 and an LDR 100. First one's infrared, second one is red. You can see the wavelengths there. Fairly high fluence and or energy density. And the idea here is that it's a very small aperture, 0.1 or less centimeters squared in circumference. So you have a lot of energy in a fairly small area. Remember, this isn't causing heat, but it's causing a huge amount of energy at a very specific point. So if you hold it long enough, you can actually help create analgesia. This is from Roberta Chow's paper. Check this out. So this is the axonal flow of mitochondria moving along axons. So I'm just going to do it one more time. So you can actually see they're dyed, and you can actually see live footage of the mitochondria zapping or zipping along the length of the axon. This is important because if this doesn't happen, that nerve flow isn't very efficient, and you reduce the transmission of the nerve itself. So what happens is when you have enough energy from a laser, it can cause something called a varicosity, which is kind of like a blockage of this mitochondria, and it causes an inhibitive effect on this anterograde transport of ATP-rich mitochondria. So this interruption of this fast axonal flow reduces the availability of ATP necessary for something called microtubular polymerization and maintenance of the resting acting potential. All that really means is that if you block this, the mitochondrial flow, you actually end up blocking the transmission of the nerve itself. And if it's a pain fiber, then of course you can cause analgesia in a very natural way. It's reversible, unfortunately, but the effects can last even up to 48 hours, and that's what the research has shown. Oh, here's a reference. Good, I actually do have it down here. So what you're seeing here is I believe it's an electromicrograph, and you can see this is a normal axon. And then when this axon was irradiated with 830 nanometers, that's exactly the wavelength that we use in our laser probes, by the way. You can see what happens. It creates this varicosity, so a blockage. And this was after 30 seconds of 830 nanometers continuous wave of energy. And this varicosity is what actually will cause the blockage and temporary blockage of pain. It's not uncommon when you treat patients, they'll walk out of there going, wow, I feel great. And that's why. So how do you reach these deep structures? Well, first of all, you need to brush up on your anatomy, make sure you know where in this case, the dorsal root ganglion lies. And then if you want to try and access that dorsal root ganglion, you want to avoid as much as possible the bony bumps and protrusions of the facet joints and the SPs, spinous processes, and so forth. So you want to place the probe laterally and sort of posteriorly anteriorly away from the facet joints, and push in as hard as you can without making the patient scream, and get that probe as close as possible to where the dorsal root ganglions lie, and then you can zap that area, and if held long enough, you can actually produce some analgesic effect. So it's really important to understand here that when you're trying to heal up a patient with sciatica, you want to have a fairly long treatment time, not for the laser probe per se for pain relief, but more so when you're trying to affect the blood and the tissues around the sciatica. And that's really because the longer the light's applied, the greater degree of stimulatory dosage, which allows that light to accumulate into the deep tissues that are affected, in this case, usually a disc. So, we're looking at fairly deep penetration that you want. And of course, also the longer that you have the light affixed to the tissue, you can actually promote systemic effects to the immune system, which then has the ability to reduce inflammation as well. According to Castano and other researchers, in this case, they looked at 810 nanometers, and it was quite effective in reducing inflammatory arthritis. This was a model that they looked at, I believe, in rats, and they found that the longer illumination times were more effective than shorter times, regardless of the total fluence or irradiance. So in other words, those folks who say, hey, why can't I just get a really high-powered laser, like class 4 lasers, and just zap it really quickly, I can see more patients, make more money. Yeah, well, the evidence suggests that you really want to have the light on for longer because it actually has a much more dramatic effect. Okay, so how you approach treatment with our equipment. We have a specific lumbosacral protocol. This is what it looks like. We have a treatment head, which is dual red and dual infrared. And we have a high powered class 3B laser probe. And you can see the frequencies and duty cycles and the duration of treatment times. I'll kind of explain that very shortly. We always start at stage 1, a fairly low range, and then we'll start to make our way up to greater frequencies, greater duty cycles as we approach into stage 3, as that patient's progressing or plateauing with respect to their treatment. So this is a generalized protocol for sciatica. So what I'm recommending here is use these placements, and you can customize or alter them based on the orientation or the actual location of the sciatica, meaning is it right-sided, is it left-sided, is it piriformis, or whatever it is, right? So the first placement's in the upper lumbar spine. It's 5 minutes of red, 5 minutes of dual infrared. Second placement is to cover the L5-S1 region using a little bit longer, because typically this is where you see most of the cases of sciatica that originate at the L5-S1 area. So 7 minutes of red and 7 minutes of infrared. We also throw in, although it's not in a standard protocol, a final placement over the lumbosacral region, just infrared, and we'll use about 7 minutes or even 8 minutes of infrared only, overlying the lower lumbosacral region, just to give that area a little bit more dosaging. We also do oblique positions. We try to get the exiting nerve roots in the lumbosacral plexus, so right and left-sided, usually for about 5 minutes each of red and infrared. I encourage you to increase the time to 7 minutes red and 7 minutes infrared, or even 8 and 8 if it's right-sided or left-sided dominant. So for example, if the sciatica is on the right side, then I would still do both placements, but on the right side, the affected side, I might increase and customize to 7 minutes red, 7 minutes infrared, or thereabouts. Just again, because that's the most affected side, and we want to treat that area a little bit more. If it's a piriformis syndrome, you'll want to place the array a little bit lower down, and of course overlying the piriformis muscle itself. So some treatment tips. Remember the depth of the target tissue, if it's deeper, then you need longer treatment time. So if your patient's really large, then of course you need to treat for longer periods of time. And really that makes sense, because the longer you hold the light on the tissue, the more light that would accumulate to the greatest depth of penetration. Depth of penetration is determined by the wavelength. The effective depth of penetration, in other words, how far that light can go that's effective, is determined by the power, my voice is squeaking, the power of the laser and other factors like the density of the tissues and the melanin in the skin and all these other factors that you need to take into consideration. When you're using the laser probe, if you're trying to target the disc and the structures that are injured or damaged, then you'll want to hold that probe for roughly 10 to 20 seconds per point before moving it to the next spot. If you're trying to create an analgesic effect, then I recommend holding it for longer. So, you should target the sciatic nerve itself, put the probe along that sciatic nerve, and you want to hold it for longer, maybe 20, 30, 40, 50, 60 seconds. There's not a specific answer here. Patients will respond differently. Just see how they react and increase or decrease dosage accordingly. Some patients will have a rare, but it does happen, increased symptoms secondary to treatment. If this is occurring after every session, you need to lower the dosaging. It can happen, so just be careful with that. It's not causing any problems, but and it's not usually over the nerve, it's usually over the inflamed area, that if you increase the dosage too much, it seems to have a temporary aggravating effect. Yeah, I mean, it does happen, but I wouldn't be overly concerned about it, but you would want to mention that to your patient just in case that happens. And it doesn't usually happen on subsequent treatments. It may occur if you change the parameters. So just keep that in mind as well. Okay, a case study. So this is a case in our clinic here. It was a 39-year-old, so relatively young person in their 4th decade of life. As I mentioned earlier, that's the age range oftentimes for this type of problem. Patient had similar episodes in the past. They had an MRI. The gentleman had bulging discs at L4-5, L5-S1. That's usually the common area where you'll see that. There was some scoliosis due to muscle spasming in the thoraco, lumbo, and sacral region, tenderness, point tenderness, and of course other orthopedic tests going on there. The MRI indicated a small central disc bulge centrally, L4-L5, and a bulging in the lateral recess on the right side. So the right side, note that, and it was compressing some of the nerve roots. So how we approached this is fairly aggressively. We had that patient come in 4 times the first week, and then we tailored off into 3 times a week for the first few weeks, and then into twice a week thereafter. We added a bit of massage into the 2nd and 3rd week, and then not until the 3rd and 4th week, as the patient was getting better, did we start to talk about some stretching and strengthening and some other activities that they could tolerate. The protocol looks something like this. Because they were having issues in the thoracolumbar region, we did add an extra placement you can see here. We increased the length of time of treatment at the L5-S1, and on the right side, you can see the red indicates a little bit longer. That's the 8 and the 7 for red, and similarly, we did extra placements vertically over the thoracolumbar and the lumbosacral region. That is the 7 minutes and the 6 minutes overlying these regions as well. And we used the laser probe. Obviously, we started off at about 40% power that's the LDI, the infrared probe, 100% power for the red. Red light, by the way, has a very strong analgesic effect. And that's why we always put it in there. That red light's not going to go to the disc or anywhere deep, but it will offer some analgesia and pain relief at the level of, at a superficial level. And then as treatment progressed, you can see that we started to increase the duty cycle of the dual array. We increased the power of the LDI 200 to 100%. Sorry, that should be 100%. And then again, as treatment progressed, we started to pulse out the red a little bit. And then we started to increase the duty cycle substantially of the dual infrared up to 250. And as we try to get even more stimulation, you can see we started to throw in much higher frequencies as well. We do find that patients adapt a little bit to frequencies so that we oftentimes will increase them just to get a bit more stimulation. You're not increasing the dosage, you're actually stimulating in a different way, which I can't really get into right now. So clinical outcomes, you can see this is going to be a long treatment plan, close to 30 treatments. However, at that time, they had marked improvement. They weren't taking any drugs for pain relief. The ADLs were pretty much back to normal, back to work. We continued on with some maintenance care, 1 session per week for several sessions. So overall, about 30, 35 sessions before they were discharged from care. All right, well, that's the end of my webinar. Hopefully you found it interesting. Please type in your questions. I'll get to those very shortly. I do want to encourage everyone, if you haven't attended one of our trainings, we have one next Friday. It's 9 a.m. Eastern Daylight Time in Toronto until about 4 or 4:30 with a 1-hour lunch break. It's only $199, so a fairly reasonable price, I feel, for an all-day event. I go over in detail the physics, the mechanisms of action, the clinical indications. I'm joined by Slava Kim, our clinical director, as well. It's a really good educational experience to learn more about. If you're new to laser therapy or you haven't yet taken it, it might be a decent idea to do that. We also have one in November as well, if you can't fit in October. It's usually on a Friday. So October the 16th and November the 20th are the next training sessions. So let's get to the questions. I'll pull those up right now. Let's see here. Okay, so let's see here. So someone has our first generation arrays, and that's fine, 750, 100, 1500 arrays. Are these protocols different? The protocols are in fact the same, Sophia, same intensity, same dosage, but you of course would have to do the red first and then the infrared afterwards. We do find overall our new dual arrays have seem to have a better effect overall, and that's because immediately after you do the red, you do the infrared as opposed to waiting before you put the infrared on. Another question from Sophia is, what would you do with people with sciatica pain that are large folks versus someone that's very lean? So again, if they're quite large, then I would increase treatment time or hold the probe longer, try and push in longer or push in harder, just to have more of a dramatic effect if possible. A question from Ismail, if sciatica is only one-sided, you would still place laser on both sides? No, the laser probe, I'm just going to treat on the affected side, but those big arrays, I'm going to treat them all the way around the spine, just to induce more of a systemic reaction. But if I'm treating right-sided sciatica, I'm going to focus on the right side of the spine and the right actual sciatic nerve itself. Do you have any other advanced training sessions planned? Yeah, so I'm working on trying to do a masterclass online with a guest, Dr. Ashley Banjan out of Durban, South Africa, who's a neurologist. So I just haven't figured that out yet, how that's going to work, but I'm hoping to have that in the fall time, which it is now. So maybe in November, I might do that, or early January. A question from Lori, my client has sciatica, has good days after treatment. The next appointment, she was kind of sore, we're 10 treatments in. Yeah, so it's hard to say, Lori, if the soreness is post-laser specific or just other factors going on. We all know that sciatica can have its flare-ups. Just try and monitor it and see if you're doing anything differently when she's sore after treatment. It could be a position of how she's positioned during the treatment. That is a physical position, you know, if she's on her stomach or on her side or whatever. So you can fool around with that as well. And you may also need to lower the dosaging if she's being temporarily aggravated. A question from Angela, in case described, was any osteopathic or chiropractic treatment given in addition to just the massage therapy, Angela? In that particular case. But, you know, I'm a chiropractor, so I'm going to be doing manual therapy as well with these patients, typically, unless they can't tolerate it. You can watch this webinar again. We will send out a link to watch the webinar in a few days or next week, so stay tuned for that as well. If a patient has drop foot, then obviously there's motor involvement, and the treatment's going to be the same, but the prognosis is not as good because there's quite a bit of compressive force on the nerve roots of the nerve. Everyone, thanks very much for joining me. I really appreciate your time, and I have a webinar in 2 weeks' time. Just go to our website to get more details. Take care.